Matt, you need to unmute.
Okay, so thank you so much, Karen, and welcome to all of you. It's good to see so many of you online, particularly the fellows. This meeting is for the fellows, by the fellows. So I'm happy to see most of you online. I'm sure the others are just running late and will join. Welcome. I'm very glad that we could get this going. This, as you know, is the very first session of the Teaching Fellows Gecko. The plan is that it's a dedicated platform, which makes it slightly different from the other geckos, where there are other consultants and experts. And here what we wanted to do was just to create a community of practice where you'll be free to ask questions, not to feel like you're dumb or that you should know this or you shouldn't know this, where you can ask your peers and really just engage at the fellow level. This is the whole point of this platform. So I hope you do feel welcome and that, as I say, you will feel comfortable to just to ask questions, to learn as much as you possibly can, which is not possible on the other platforms. As you know, we did a 2-year cycle trying to cover the entire curriculum over a 2-year period. And we're going to start with the gut, so the esophagus, stomach, small bowel. That will probably take us to the end of the year. And then we're going to do hepatology at the beginning of next year, and the modules end with IBD. And the reason I did it that way is because we do have Gecko IBD, so you'll still be getting some IBD from those sessions. The program has been filled in for the 2 years, but we'll send it out to you in quarters. That will allow for any changes that need to be made. As you know, the fellows prepare the talks, and you must please consult with the facilitator. We haven't yet compiled the cell phone numbers and the email addresses of the facilitators, but they've all agreed to share those with you so that if you're presenting and you need to just find out how you should approach the topic and what resources you need, etc., you can directly contact them. All of the heads of divisions, all of the heads, the facilitators are very happy for you to do that. So please use that resource. It's also a way for us to communicate what is working, what is not working, what you'd like to see, and we can try and improve this program as we go along. So I didn't want to set a separate meeting for the introductions and how to go about things because it was early in January, some people were on leave. Also, I figured that there's no need to waste a slot. There's so many meetings and people have got so many other responsibilities. So I was trying not to take up too many Zoom meetings and use up one for the introduction, because I think we did it at Spear and you guys generally have an idea of what we're trying to do here. So I hope that is clear and I hope you benefit and derive pleasure from this program as we've had in putting it together, along with your HODs, Professor Spearman, Chris, and others. So today I thought we should do anatomy and physiology. And the reason is very, very simple. That I find that with specialties that are hands-on, it's very easy to forget about what is happening at basic science level and get carried away with the endoscopy and those sorts of things. And you could generally cruise through gastroenterology without understanding the anatomy and physiology of the gut. And I just think, the fact that we don't examine that specifically is a problem. So I thought we should start with the foundation. It's not the most exciting talk, and this is not Barbara's fault. Basic science is basic science. You can't make it sexy. It's just information that you need to know. And I'm hoping that from what is being said today, going forward, you will find applications for the separate subsections that you come across. So Barbara has done a fantastic job in putting this talk together. She's done a lot of work. And she's kind enough to allow us to put this on the website so that the rest of you don't have to go and reinvent the wheel. The information is all there. Obviously, we won't go verbatim on this information today, but I think it serves as a nice basis to refer to when you're reading your other more specific disease entities. So today is quite a lot of stuff. Please try to take in as much as you can, but as I say, the recordings will be available afterwards. So we let Barbara do the talk. I won't interrupt because it will interfere with the flow. And then we'll see if there are questions at the end. I suspect there won't be time for that. And also I'm just asking for a bit of patience because I think today we may run a little bit late because the topic is intense. there's a lot to cover, but also I had to do this sort of introductory comments. So without further ado, Barbara, thank you so much for doing this, and I'm going to hand over to you, and then we'll speak to the others when you're done. Thank you so much.
Good evening, everyone. My name is Dr. Barbara Makumbi. I'm from the Mid Circuit at Charlotte Maxeke Academic Hospital. Today I'll be discussing the anatomy and physiology of the upper, mid, and lower gut. So an outline of my talk, as I said, the upper, mid, and lower gut. Upper consisting of the oral cavity and pharynx, esophagus, and gastric anatomy physiology. The mid gut, the small bowel, and the lower gut, the colon and the rectum. To begin, let's talk about the oral cavity. We're going to talk about the salivary glands. I'm going to do a quick overview. 3 important salivary glands to take note of: the parotid, the submandibular, and the sublingual glands. Saliva secretion is important to moisture in the mouth and facilitate speech and taste. Xerostoma, a dry mouth, actually results in dental caries. So saliva is important to keep the mouth clean and for antibacterial component. And it acts as a buffer, pH of 7 for reflux from the stomach. Saliva consists of amylase, immunoglobulin A, and lysosomes. And the consistency of saliva varies from a proteinous to or mucinous consistency, depending on the parasympathetic and sympathetic innervation, and a number of other reflexes and factors. We produce 1 to 1.5 liters of saliva a day, and it's a hypotonic solution. I'm not going to go extensively into the mechanisms of swallowing in terms of all of these structures and nerves and muscles involved in swallowing. I just wanted to show you that this is how many there are, and you can read them in your own time on the website. The pharynx is divided into 3 parts: nasopharynx, oropharynx, and laryngopharynx. So that's what's illustrated in this picture, as well as showing you where the soft palate is, the epiglottis, and the cricoid cartilage. Just a quick overview of the physiology of swallowing. There's an oral phase. So when we swallow liquids, the oral cavity is actually sealed with the tongue and hard palate. Whereas with solids, there's mastication, which basically is just chewing and manipulation of the food. There's a preparatory stage and a propulsion stage, which is all voluntary in the oral phase. Then you get to the pharyngeal phase, where you have your nasopharynx. Your soft palate actually elevates with your tensor palatini and elevator palatini muscles. There's 0.5 to 1.5 seconds of swallow apnea to decrease the chances of actually having aspiration. And vocal cords need to close. You have your posterior cricoarytenoid and lateral cricoarytenoid abduct, and oblique and transverse arytenoids as well to close the glottic closure so that you don't aspirate during swallowing. So the first irreversible step of swallowing is when the food bolus actually gets to the palatal glossal arch. We have lots of afferent sensory nerves that send impulses to the solitary tract nucleus in the brainstem. And you have efferent muscle fibers in the larynx, pharynx, esophagus that all help to coordinate your reflex swallowing. Your superior, middle, and inferior pharyngeal constrictor muscles then form a peristaltic wave and increase pressure to the upper esophageal sphincter. There's relaxation of the sphincter, and then we begin the esophageal phase, where there's more peristalsis, and we get to the lower esophageal sphincter. And I'll give you more detail on the structures of these UES and LES later in the talk. Just to bring it to a clinical standpoint, I just wanted to talk about the anatomy of intubation when it comes to gastroscopy, just briefly. Just going to the end, we have your piriformis fossa here, where you actually end up putting the scope down. But just for time's sake, I'm not going to go through the whole diagram, but this is a very interesting diagram to look at. The gross anatomy of the esophagus, going on to the esophagus now. It's a hollow muscular tube which is 18 to 26 centimeters in length. It's composed of stratified squamous epithelium, and it expands anterior posteriorly by 2 centimeters and laterally by 3 centimeters. In terms of its musculature, the upper 5 to 33% of the skeleton of the esophagus is skeletal. The distal 50% or so is smooth muscle, and then in between, it's a mixture of smooth and skeletal muscle. So the UES is made up of the inferior pharyngeal constrictor, the cricopharyngeus as well, and that's made of skeletal muscle as it's in the upper part of the esophagus. And it's also composed of the inner circular and outer longitudinal muscle, which makes up the whole length of the esophagus. The body, which is found in the posterior mediastinum behind the trachea and the left main bronchus, it actually swings to the left side behind the heart and in front of the aorta. At T10, it leaves the thorax and enters the right crew of the diaphragm. The lower esophageal sphincter is 2 to 4 centimeters in length. It's asymmetrical and thickened with smooth muscle as it's part of the distal esophagus. And it's also composed of the phrenoesophageal ligament, which allows for fixation of the lower esophageal sphincter. In this slide, I wanted to highlight the structures that surround the esophagus and the indentations you'll find in the esophagus. So as you scope, you'll also find that you can see the aortic arch, the left main bronchus, and if the left atrium is hypertrophied, you can also see an indentation of the left atrium. In terms of the histology, as I think we all know, like from top to bottom, we basically have the same layers in the GIT with differences in different parts, but mostly the same. You have your mucosa, made up of your epithelium, your lamina propria, and the muscularis mucosa. Then you have your submucosa and your muscularis. Here in the esophagus, you have your inner circular and your outer longitudinal. And then you either have an adventitia and a serosa. The esophagus actually doesn't have a serosa. Just a little bit more detail about the mucosa of the esophagus itself. The epithelium, the stratified squamous epithelium, actually has 3 functional parts: the corneum, the spinosum, and the germinativum. So the last part has a basal layer of cuboidal cells, and usually it makes up 10 to 15% of the thickness of the epithelium. But if it makes up more than that, then we have basal cell hyperplasia, which is a sign of GORD, actually. We look at a Z line, which is important because it's the gastroesophageal junction, and it demarcates squamo-columnar junction between the esophagus and the stomach. So you have your lighter esophageal mucosa and your redder gastric mucosa. I'm going to just do an overview of the innervation. It's quite detailed, but you have parasympathetic innervation, which is mainly by the vagus nerve, and your vagus nerve goes to your medulla. You have your nucleus ambiguous, which controls the skeletal muscle, and the dorsal motor nucleus, which controls the smooth muscle. Basically, with your vagal preganglionic efferents, smooth muscle in the distal esophagus so it goes to your myenteric plexus, which is between your circular and your longitudinal muscle, and then your meisnus or your submucosal plexus also gets innervated. So in terms of sensory, it's important to note that, okay, you have vagal afferents, but pain sensation is by your chemo and mechanoreceptors, and there is a thoracic nerve root that is a common thoracic nerve root with other structures in the mediastinum. And because of the overlap with embryonic development between these structures in the esophagus, you can have pain as a chest pain syndrome, which is very difficult to differentiate sometimes clinically between cardiac, for example, and gastric chest pain. In terms of the circulation of the esophagus, looking at the arterial circulation, it's divided into your upper, mid, and lower, cervical, thoracic, and abdominal. branches of your superior and inferior thyroid for your cervical, thoracic, your bronchial artery, right intercostal and descending aortic branches, and abdominal, your left gastric artery, left inferior phrenic, and splenic arteries. Venous drainage is also divided in the same way. Your superior vena cava, your azygos, and portal circulation, which is quite important clinically, via your left and short gastric vein. You have systemic azygos vein, as well as your portal circulation together, actually. So you have your portal systemic anastomoses subclinically, which are important for esophageal varices. In terms of lymphatics, the esophagus is very rich, mucosally and submucosally, and like lymphatic drainage systems, also divided into those thirds again, and they're very interconnected. So when it comes to esophageal CA, in terms of metastases, the cancer can spread very quickly because of the interconnected channels of the lymphatics. Moving on to gastric, your stomach is a J-shaped dilatation. It's a reservoir, and it's used to store large quantities of food. You can store up to 1.5 to 2 liters, and it's divided into 4 regions depending on anatomical as well as histological landmarks. So your cardia is small, ill-defined, and possibly controversial in terms of histology. This is the part of your stomach that is adjacent to your esophagus. Fundus projects above the cardia and the OGJ. It's dome-shaped, and it's most superior and adjacent to the left hemidiaphragm and your spleen. The corpus is the largest part, and this is directly below the fundus. Then you have your incisura, which is fixed in a sharp indentation, and your antrum, which is from your body to the junction of your pylorus. Your pylorus, you have your pyloric channel, which is a tubular structure joining the stomach to the duodenum. And then you have, this is consisting of a palpable circular muscle and sphincter. This is mobile, and it's enclosed between the peritoneum of the greater and lesser omenta. It's 2 centimeters to the right of the midline of L1. Gastric arterial supply basically consists of branches of your celiac. So you have your celiac, let me just show you here, your celiac trunk. Your celiac trunk has 3 main branches: your common hepatic, your left gastric, and then your splenic, which runs over here to your spleen. You have 2 arterial arcades that actually meet on your lesser curvature and your lower 2/3 of the greater curvature. Lesser curvature is supplied by your left gastric artery, and your greater curvature, so left gastric artery, just to summarize, and the greater curvature just below the fundus is supplied by your left gastroepiploic artery, which is a branch of the splenic. And below from underneath, the right gastroepiploic comes up and anastomoses with the gastroepiploic to cause an anastomosis here. Gastric fundus, as I said, is a separate arterial supply from this part of the stomach. So the fundus is actually your short gastric artery, which is actually a branch of your splenic. And this all becomes important when it comes to arterial bleeds. When somebody has a peptic ulcer and there's a bleed, it's important to know this diagram. Your gastric venous supply basically accompanies the arteries. The veins basically empty into the portal vein or branches of the portal vein. Your lesser curvature is drained by the left and right gastric vein, and your inferior part of the stomach and greater curvature are drained by the right and left gastroepiploic vein. Lymphatics, to summarize, there's 4 groups of, the stomach is actually divided into 4, and there's 4 groups of lymphatic nodes, basically celiac nodes, hepatic nodes, splenic nodes, and suprapyloric nodes, to name a few. But I think that's something you'll have to go over in detail. In terms of innervation, it's your autonomic nervous system, sympathetic, parasympathetic. You have your preganglionic T6 to T8, that's synapses bilaterally with celiac ganglia. And then you have your celiac plexus as well, and parasympathetic, the right and left vagus. And yeah, quite detailed, but again, your Meissner's and your Oberback plexuses come in, and these innervations are all distributed into glands and the smooth muscle. We've basically touched on this with the esophagus, but just to give you detail on the stomach, mucosa is smooth and velvety. Your cardia, antrum, and pylorus are much paler than your fundus in the body. The fundus and the body have the functional secretory elements of the stomach within them. And then you have your epithelium, lamina propria, and muscularis mucosae. You have your submucosa, your connective tissue skeleton with collagen and elastin. These also contain lymphocytes, plasma cells, arterioles, venules, and lymphatics, and your neurological plexus. Your muscularis in the stomach, which is different. You have your inner oblique, your middle circular, and your outer longitudinal. The oblique actually crosses over the fundus, covers the anterior and posterior wall of the stomach. Circular encloses the stomach, thickens distally at the pyloric sphincter, which I mentioned earlier, and the longitudinal goes along the greater and lesser curvatures. And then the serosa, which is transparent, and it's a continuation of the visceral peritoneum. In terms of histology, just quickly, that the mucosal surface is actually simple columnar epithelium, a number of cells in the stomach, but surface mucus cells are similar throughout the stomach. The mucus cells have mucus granules that secrete mucus through exocytosis and apical expulsion and self-exfoliation. So you have your mucus and bicarb in the stomach that are cytoprotective against acid, pepsin, and any ingested substances and pathogens. The cell renewal time for the cells is 3 days. You have gastric pits. These are invaginations of your surface epithelial lining. Glands access the lumen via these gastric pits. The ratio of 1 pit is to 1 is to 4 or 5 gastric glands. The gastric glands are different in different anatomical parts of the stomach. Cardia, you have, in terms of the epithelium in the cardia now, you have a small transitional zone of stratified squamous to columnar. The glands here are branched and tortuous with mucus, endocrine, G cells, and undifferentiated cells. In the second region of the stomach, there's a gradual transition to acid-secreting segments. This is your fundus and your body, which I said are the more pinker parts. A very important gland is your oxyntic gland, fundic gland as well, which is composed of parietal, chief, endocrine, mucus neck, and undifferentiated cells. Most numerous and distinct gastric glands, they secrete acid, intrinsic factor, and gastric enzymes. They are straight and they're tubular simple cells. They're divided into 3 regions. The isthmus, which is composed of your surface mucus cells more than any other cells. In the neck, which has your parietal mucus neck cells, and your base, which consists of chief cells. Some parietal mucus and neck cells as well. So you have endocrine cells, somatostatin secreting D cells, histamine secreting enterochromaffin cells, ECL cells. And there's a diagram just illustrating what I've said. Your ECL cells secrete your histamine. Chief cells secrete pepsinogen. Parietal cells, acid, intrinsic factor, and your mucus neck cells, which I'll go into more detail in a second. So in terms of the parietal cell, that's the principal cell of this gland. It is responsible for hydrogen ions being secreted. It has large mitochondria. It has microvilli that lack glycocalyx, and it has a cytoplasmic canaliculi system that's in contact with the lumen. So you have a non-secreting and a secreting version of the cell. Your non-secreting version actually has cytoplasmic tubulovesical system, more than like your short villi that line the apical caniculi. When it's actually ready to secrete, these tubulovesicular systems actually disappear, and it leaves intracellular caniculi and longer microvilli to facilitate their function. So 40% of the cell volume is mitochondria. So lots of energy is needed for secretion across the microvilli, the apex. And then you have your proton pump, your hydrogen potassium ATPase pump, which is found in the apical microvillus membrane. And this cell also has a carbonic anhydrase enzyme. Acid secretion begins 5 to 10 minutes after stimulation. Intrinsic factor is also via membrane-associated vesicle transport. So this is an illustration of the parietal cell proton pump. It basically illustrates what I will go into soon: gastrin, acetylcholine, histamine, all receptors that are present that also increase activation. Other cells, which I have actually mentioned, the neck cells, just to give you more detail about the neck cells of mucous neck cells. These cells are found in the neck or the isthmus. They're single or in groups of 2 or 3. They are involved in the synthesis of mucus that's acidic, and they have basal nuclei and larger mucus granules around the nuclei. So I put this table on to illustrate that you have mucous neck cells and mucous surface cells. Mucous neck cells have different function from mucous surface cells. The surface cells secrete neutral mucus, whereas the neck cells have acidic mucus. The mucous surface cells are cytoprotective and have apical granules. And here, as I've said at the bottom, the mucous neck cells are actually stem cell precursors for surface cells, parietal cells, chief cells, and endocrine cells. Other cells that are present, I briefly mentioned the chief cells. These are zymogen cells that are present in the deeper layers of the glands, pyramid-shaped pepsinogen secretors. And then your endocrine D cells for somatostatin and ECL and enterochromaffin. The enterochromaffin actually mostly secretes serotonin. I'm going to quickly just give you an overview of gastric secretion and digestion. There's a cephalic phase where you have vagal input and you're thinking about food and the secretion starts. Gastric phase, which is the quantitatively most important phase, and then intestinal phase. G cells secrete gastrin from your antrum. You have gastrin-releasing peptide, GRP, that is released in response to oligopeptides in your lumen. So your oxynitic cells, glands, with your parietal chief cells and your enterochromaffin cells, which I've briefly said, acetylcholine from the enteric nerve endings, and your histamine as well as your gastrin will increase secretion of these cells. Then there's a hormone GIP from the K cells of the duodenum, and also gastric mucosa that's secreted, and that increases the absorption of glucose and fat. And then there's a large in a large quantity, the GIP actually inhibits gastric secretion and motility. Then CCK, secretin from the pancreas. D1 stimulates pancreatic enzyme, from D1, so it stimulates pancreatic enzyme secretion. Moving on to the small bowel. The small bowel is 600 to 800 centimeters in length on average in an adult. The duodenum decreases in caliber from the proximal to the distal end. There's a 4 times decrease in surface area from the distal duodenum to TI. And it's obviously the most proximal part. It's a C-shaped loop. It loops around the head of the pancreas. It's 30 centimeters long and divided into D1 to D4. D1, the duodenal bulb or cap, is about 5 centimeters. It goes right, up, and back, and it's retroperitoneal. It returns to the peritoneum at the ligament of Tres, and it's loosely attached to the liver at the hepatoduodenal portion of the lesser omentum. It moves in relation to the pylorus, and posterior to D1, you have your gastroduodenal artery. This is important because if you have a D1 bleeding ulcer, you can erode into this artery. You have your bile duct and your portal vein, and anterior to this is your gallbladder. D2 is 7 to 10 centimeters in length. It goes down and parallel and in front of the right kidney. And on the right side of D2, you have your head of pancreas. With D2, the posterior middle wall, you have your major papilla, your ampulla of Vater, which is a nipple-like projection. But in some patients, you may get an accessory pancreatic duct, a minor duodenal papilla, which is 1 to 2 centimeters proximal to the ampulla of Vater. D3 is 10 centimeters in length, transverse from right to left, from right to left across the midline. Posterior to D3 is the IVC, the spine, and the aorta. Anterior to D3 is the superior mesenteric artery and the vein. D4 is 5 centimeters in length. It goes up and to the left of the aorta, and it reaches the inferior border of the pancreas. You have your duodenal-jejunal flexure, which is a fixed point of the ligament of Charles, actually. Proximal duodenum is innervated in arterial supply by the right gastric, the supraduodenal, the right epicloic, and the superior inferior pancreal duodenal artery. Distal to the duodenum, jejunum, and ileum. Distal duodenum, jejunum, ileum, ascending colon, and the proximal 2/3 of the transverse colon are all innervated by branches of the SMA, and the remainder of the colon has inferior mesenteric artery arterial supply. Venous supply corresponds with your arterial supply, and then these are the lymphatics associated with the duodenum. More detail on the rest of the small bowel. Your jejunum, it makes up 40% of the freely mobile small bowel, and the ileum makes up 60%. So within the peritoneum, these are within the peritoneum and suspended by mesentery. Your mesentery is thin, broad-based, fan-shaped. It's an anterior reflection of the posterior peritoneum, and it's attached to the abdominal wall. It extends from the left to the right sacroiliac joint. And this allows free movements, but it's still tethered. The jejunum is actually thicker and more vascular and has a greater diameter. And then you have your plicae circularis. These are folds that are prominent proximally, so in your jejunum, and they decrease distally, and there's none in the terminal ileum. You have lymphoid aggregates, which are microscopic and scattered throughout the small bowel. And these are your galls, your GI-associated lymphoid tissue. As well as macroscopically, you can have Peyer's patches. In the ileum, they extend to the serosa, and you have many in infancy and childhood. To just show you the ileocecal valve, 2 semi-lunar lips, and it's a flatter valve. It allows anterior grade flow and opens with peristaltic wave, prevents the colon from refluxing into the terminal ileum. It's an angulation, and it's supported by the superior and inferior IC ligaments, which are actually very important for the function of the valve. It contracts with distension of the cecum, and this we see when we're trying to get into terminal ileum. If you distend the cecum too much, you will close the valve. And the distal terminal ileum is actually retroperitoneal. The colon. So the colon is 150 centimeters in length in the average adult. It begins at the IC valve and ends at the anal verge. 4 segments are present: the cecum, the vermiform appendix, the actual colon, the rectum and anal verge. So in this diagram, I was just illustrating with also colonoscopy, the different lengths of the different parts of the colon. And to correspond with when you are actually doing a colonoscopy to see how far you should be. These measurements are quite helpful. The diameter of the colon is greatest at the cecum, which is about approximately 7.5 centimeters, and it's the narrowest at the sigmoid, which is approximately 2.5 centimeters. And then after the sigmoid, it then balloons into the rectum. So features that are defining features of the colon are its large caliber, its fixed position, and then the outer longitudinal muscle fibers. So these are your tinea coli. They are 6 to 12 millimeters in width, and the thickness increases from cecum to sigmoid. You have 3 different types, the free, omental, and mesenteric, and they basically have 120-degree intervals between them. Then you have your hostra, or outpouchings, between the tinea, and in the mucosal surface, you actually have semiluminar folds, and serosa have like sacculated puckered appearance as well. And you have adipose tissue, which are your appendices plicoa, which are seen on the external surface. So mesentery fully suspends your transverse colon and sigmoid colon, but the remainder of your colon, only mesentery found on the free anterior surface. Your appendix has a short mesentery called the Meso Appendix. Just to go back to the cecum, as I said, it's the most proximal. It's 6 to 8 centimeters in length and breadth. It's found in your right iliac fossa, and it projects down as a blind-ended pouch below the entrance of the ileum. It's actually quite susceptible to perforation, especially with distal obstruction, and its thin layer as well. If a mass is found in the cecum, it's allowed to grow to a substantial size compared to other places in the colon. It's non-mobile, it's fixed in position. And then we've spoken about the IC valve, as well as now the appendiceal orifice is present in the cecum, which is about 2.5 centimeters inferior to the IC valve. And then the verruliform appendix, which is blind ending outpouching. The ascending colon, this is 12 to 20 centimeters from the level of the IC valve to the inferior surface of the posterior liver. You have your hepatic flexure that angulates to the left. The ascending colon is covered in peritoneum and it's retroperitoneal in 75% of the population. The transverse colon is the longest part of the colon. It's 42 centimeters in length, fully enveloped in mesentery, and most mobile part of the colon. It has the phrenocholic ligament that anchors the colon to the splenic flexure. When somebody stands upright, the transverse colon can dip into the pelvis. That's how mobile it is. But in patients with previous abdominal and pelvic surgery, you can get adhesions, and this actually makes the colonoscope much more difficult with decreased mobility. The descending colon is 25 to 45 centimeters, and this travels posteriorly and inferiorly in the retroperitoneal compartment to the pelvic brim. This emerges from the retroperitoneal component, so it emerges, from the retroperitoneal components into the peritoneal cavity. Then you have your sigmoid colon that's S-shaped, it's redundant segment. It has variable length, it's tortuous and mobile. It's the narrowest part, it's susceptible to volvulus. And then if a mass does actually form in your sigmoid, you will get obstructive symptoms pretty quickly. Rectum, 10 to 12 centimeters in length on average, and it begins at the peritoneal reflection. It follows the curve of the sacrum and passing down posteriorly and ends in the anal canal. There are no sacculations, appendices, or mesentery in the rectum. The outer wall is progressively thickened, and it has prominent anterior bands of muscle. It has 3 transverse folds called valves of Houston, and has the rectosigmoid junction that narrows and expands in the anus. The anal canal is 4.5 centimeters in length. It's in the ischiorectal fossa, inferior and outward towards the anal opening. The anorectal junction itself is 2 to 3 centimeters anterior to the coccyx. The pelvic diaphragm is part of, it's in the near the pelvic diaphragm with the levator ani, the coccygeus, and the puborectus muscles. You have your internal and your external sphincters. Internal sphincter made out of circular smooth muscle, external sphincter striated muscle, anal canal, and then fibers that blend in the levator ani and attach to the coccyx and the perineal body. This is basically what I've said. Distal, but the components of the anal canal distally are the anal verge, which actually have the anoderm and then true skin. So the anal verge is over here. And then the mucosa, distal 3 centimeters of the rectum and the anal canal. So there's 6 to 12 redundant longitudinal folds and columns of Morgani that terminate in the anal papillae. And the columns joined together by mucosal folds and anal valves are situated by the dentate line. So I just wanted to illustrate. So we have your anal canal, which is this region over here, and then your anal sinus with the anal column. And they talk about an anal crypt that's here with an anal gland involved. I've talked about the anal verge, and this is the dentate line. Some sources use the dentate and the pectinate line interchangeably, and others don't. And that's basically it there. Sorry, this is the internal sphincter here, and then the external sphincter, deep and superficial externally. The vasculature of the colon is the SNA. I think we've already covered this, so we can just have a look at this when the slides are posted. And then basically the same thing that we have spoken about, arterial, and then the venous, systemic and portal systems. That's important to note because of portal hypertension complications. Lymphatics of your colon, also something that you can read, but basically it's the celiac, pre-aortic, inferior aortic regions, and it follows the arterial and venous, supply, basically with the vessels. Colon innervation. So they talk about extrinsic, intrinsic, and endocrine, which are important. Your enteric nervous system, as well as your gut endocrine system, which have a multitude of functions. I'm going to go on to the histology of the small and large intestine as one, just to summarize. So your mucosa, the same basic structure as the whole GIT. So in the mucosa of the small and large bowel, they're somewhat similar, but in the small bowel, you have villus projections. You have 400 to 500 increase in surface area. They project 0.5 to 1.5 millimeters into your lumen. And the height actually decreases as you move more proximately to your distal small intestine. Okay, so the villi in your small bowel in D1 and proximity are actually wider. And then they actually become more finger-like and elongated as you move down into the jejunum. The villi are covered in mature enterocytes and interspersed goblet cells. And each villus consists of an artery, vein, a central lacteal, nerve fibers, plasma cells, macrophages, eosinophils, fibroblasts. And there's a capillary network as well that's surrounding along the epithelium, allowing for absorption, and the capillary walls are fenestrated. So the mucosa is thick, vascularized, and also there's concentric folds of plicae seculae, which you've spoken about, and there's glandular tissue. So villi are surrounded by crypts of lubricant, and these crypts in the small bowel extend into lamina propria and muscularis mucosae. They're lined with immature epithelial cells that actually primarily have secretory function. Different types of cells are included in the small bowel. To highlight a few, we have absorptive cells that are basically high columnar cells. You have secretory goblet cells, stem cells with high which are at the base of the crypts, and they have high mitotic activity. Here, they have 5 to 7 days turnover, and by the time they get to the upper third of your crypt, they are mature. And then another cell that I haven't actually mentioned yet are your Paneth cells. So Paneth cells are the only cells that actually don't migrate. They're flask-shaped with eosinophilic granule cytoplasm and broad base, and they're exclusively found in the crypt. They secrete alpha defensin, antimicrobial proteins, lysosome, and phospholipase A, and they basically maintain enteric homeostasis. Then they're undifferentiated tuft and cups-like cells, which don't function as unknown. Neuroendocrine cells, there's 11 different types. They are hormone products, paracrine and endocrine functions. You have your serotonin, your VIP, somatostatin, gastrin, a whole host of hormones that are actually secreted. I think this we can leave to be read over in our own time, and this, but I'll highlight that somatostatin is actually a growth hormone originally found in the hypothalamus, secreted by the D cells, has paracrine activity, and inhibits VIP, GIP, secretin, and motilin. I'm also going to mention glucagon-like peptide 1, which is released into circulation after a meal containing fat and carbohydrate, and it's thought to act as a part of an ileal break, partly secreted via the vagus nerve to reduce gastric emptying and small intestinal transit. So it's shown to reduce food intake in humans and stimulate insulin release. I'm going to leave the rest for us to read over on our own. There's also M cells, which are specialized, and these M cells are actually overlying lymphoid follicles and PS patches, also in the small intestine and colon. So there's a lot of overlap with some of these cells. Like I've mentioned some things that were in the stomach, but they're also in the small intestine. So luminal antigen sampling occurs with M cells, so it's important for immune processing and tolerance and host defense homeostasis. Another set of important cells are your interstitial cells of Kegel, ICC cells. They're both in the small intestine and colon. They're near the myenteric plexuses within muscularis propria and submucosa. They're important for regulating peristalsis and pacemaker cells. They allow for smooth muscle contraction. They amplify neural signals and mediate neurotransmitters and membrane potential gradients. So these are spindle-shaped cells with long ramified processes. They express c-KIT, CD117 tyrosine kinase receptor, which are critical for their survival and associated with just tumors. The micro of the small and large intestine, continued with the submucosa, the Meso plexus. Then we have Brunner's glands. Brunner's glands are found in D1 and decrease in size distally. In children, you can also find them in the jejunum. They secrete bicarb, which is alkaline, and they neutralize chyme. The secretions drain into the base of the duodenal crypts and increase luminal pH. They promote pancreatic secretion of gall bladder contraction. They also have glycoprotein. Then your muscularis propria, which we've talked about, and your serosa, which is a thin layer of mesothelial cells and an extension of the mesentery and envelops the intestine. This highlights the 3 zones of the anal canal. In terms of the dentate line, we just said that the dentate and the pectinate line can actually be used in some texts interchangeably, but they're actually different. The dentate line is the proximal margin contact with the anoderm, and then the pectinate line is a distal margin contact with the anal skin. And then you have anal skin, which is squamous stratified epithelium with hair and sebaceous glands. Lymphatics in the small intestine, we talked about the villi, the lacteals that are there filled with milky white lymph and chyle, and each villus has one, except in the duodenum where it can be 2 or more lacteals and endothelial cells. In terms of nerves, I think we've highlighted that. And this almost brings us to the end of the talk. I just thought this was quite an informative diagram when it comes to absorption of different nutrients, micronutrients, and elements, basically. Also something that we can also go over in the slides are posted. These are my references, and thank you for the opportunity to present.
Okay, thank you, Barbara. That was quite a draconian task because this is a broad topic, very, very detailed. And I think you've done an excellent job in covering the spectrum of what I think is important to know. And I think for the fellows, especially the ones that have just joined the program, this is the level of detail that we expect you to know. Yes, we don't examine it in a basic science paper. There has been talk of introducing a basic science paper. But as it stands, that's not what we're doing. But I think in order to understand diseases, pathology, understand the histology that you're given by pathologists, understand motility studies, and of course, even functional studies, which we don't tend to do in clinical practice, you really need to understand what's happening at molecular level. I have some slides to try and summarize what Barbara has said. If there are any questions, you can ask me after that. I just thought, and basically what Barbara has shown you are the functions of the gastrointestinal tract. And if you understand that every section, every organ, including the accessory organs that are involved in digestion, whether it's mastication, chewing, propelling bolus down, transporting the bolus, chemical, mechanical digestion, absorption, etc. At every stage of the process, each cell type, the histology, the anatomy, the structures are all differentiated for that task. So for instance, for the esophagus, it's just a hollow tube whose function it is to transport food down. It doesn't need to have any sophisticated epithelium that's going to absorb nutrients, etc. That is not its function. And ask yourself, why is the squamous epithelium that is stratified of the esophagus different from that of the skin? And why is it similar to the stratified squamous epithelium of the anus? There's very good reason why that is. Ask yourself, what is the function of the muscularis mucosa? What function and what purpose does it serve? Barbara said that the esophagus does not have a serosal lining, but has an adventitial lining. There's another part in the gut that has adventitia and not serosa. Why is that? What is the function of the serosal surfaces? What is the function of the adventitia? Why is the lining of the stomach simple columnar? The purpose of all those glands that secrete mucus, what are they there to do? Think about your accessory organs, so the pancreas, the liver that secrete bile acids and detergents that you need for digestion. This diagram doesn't talk about the immunology. Remember that the gut is one of the organs that's directly connected to the external environment. It needs to sample allergens, sample antigens, and not overreact in terms of its immune response to these things that it is detecting. So the role of the immune system is not depicted here in this diagram. The role of the gut and microbiome in health and disease is another thing that is not specifically highlighted. So there's a lot to think about and how each section is adapted specifically to its function. And then there's lots of application. I mean, it's obvious that in order for you to understand diseases, etc., you need to understand what's going on. But the obvious applications for you as fellows is now when you take a history from a patient with dysphagia, Think about oropharyngeal dysphagia. All dysphagia is not created equal. Some of it is a problem in initiating swallowing. Some of it occurs after swallowing, voluntary swallowing has happened. Good that you understand that the problem is not necessarily increased acid. It's a failure of reflux mechanisms. And Barbara has spoken about that. She's talked about saliva, the buffering effects, motility, the lower esophageal sphincter, etc. Think about all the sphincters in the body. I think there's 5 or 6 of them. They function. What do they do? What are they for? What do they comprise of? Why is the bowel length longer in death than it is when we're alive? There's a huge reason for that. Understanding how the epithelial cells of the gut work will easily explain for you how acid suppressants work, their mode of action. Why you have to take PPIs, ideally on an empty stomach, but about 30 minutes to an hour before meals. What is it about the maximal suppression that makes it more effective when you take it like that? What is the half-life? What are the interactions with clopidogrel and other things? Think about the gastropanel for H. pylori in trying to determine the risk of gastric cancer. Using the PG1, so that is the pepsinogen ratio, can be very useful in helping you identify patients who are at risk of atrophy, metaplasia, and cancer. Understanding the mechanisms of small bowel versus large bowel diarrhea. Malabsorption, nutrition is super, super important in gastroenterology. And unless you understand where nutrients and vitamins and fluid and absorption of micronutrients is absorbed, you really won't manage your patient comprehensively. And then understanding FODMAPs. Why do they cause bloating and gas and diarrhea? What is the mechanism? And how does this fit into the diagnostic tests that we use to diagnose some of these things? So like lactose intolerance, like small intestinal bacterial overgrowth. So really, guys, I cannot stress enough how important it is to understand these things at basic science level so that you can easily apply them to your patients. So that when things don't fit, as they sometimes don't, you really have an understanding of where the problem is and how you'll even begin to figure that out. I put that gastro panel here with the PG1, PG2 ratio and how it can help you determine which patients are at risk and need to be screened. And also just for your interest, in case you didn't know, and in case I haven't made a compelling argument about why it's important to know this, these are the Nobel Prizes in medicine and physiology that were given to gastroenterologists in discovering really important physiological, functional things that we now understand in gastroenterology. And I haven't even included the liver hepatology. This is just pure luminal GI. So again, underpinning the importance of understanding basic science. So I had a quiz for you guys. I think you need to take the quizzes. I took the quizzes this weekend to just make sure how much I understand, how much I really understand. And I think the quizzes, there's many of them online. I've created one for you. I will send it to Karen to post. It just helps you to just have a more nuanced understanding of what's going on. There's lots of videos and stuff, but I think if you do the quizzes, then you really, really know that you understand what's going on. I think that's about all that I wanted to say. I don't know if anybody has got any burning questions before I ask Professor Spearman, who's the co-convener of this fellows course, to speak, just to share her thoughts. But as I say, this is just to have so that you can go over it in your own time. It's a lot to take in. Didn't expect you to really remember all of it. But I think it's a very useful tool to have to go back to, particularly as you're now going to be preparing talks on specific topics. I think, as I say, Barbara, I really think you did a fantastic job. Well done to you. Are there any burning questions? Otherwise, I'm going to ask Prof. Spearman. For those of you that are new, Prof. Spearman is a hepatologist. If you haven't come across her, I doubt you haven't. But if you haven't, she's a hepatologist here at Fortescue UCT. Are there any burning questions from anyone?
Let me just see. No comments, no questions.
Or comments, Noni.
Yeah, no, I just wanted to add that Barbara has done a good job out of this, and it's a first presentation for us this year. So I think, yeah, I have to reiterate, well done. I think it's an important subject which we also need to keep on visiting, especially some of us who think are experienced in this, doing scopes, and we don't know exactly where we are all the time and what are the functions of this organ. So it's quite an important reminder, actually. Important academically and practically. So thank you.
Thank you, None. Really appreciate those comments. Wendy, please go ahead. Thanks for joining.
So I think this really was an excellent first session, and Barbara's really to be congratulated on a very vast topic that really was put across very concisely. And I think going forward, what you want to do is to relate your individual topics that you're now going forward to this topic and how it actually relates, because I think that will really reinforce how the pathology works, how you're going to utilize medication, therapeutics, interventions. And I think it is try and as you go forward in your future presentations to relate it back to what's relevant from this talk. And I think that's very important. And I mean, I really would encourage you as a group to actually continue to interact with one another on these topics, problems that you don't understand, what you want to interact with and to develop further. So the whole thing is really supposed to be interactive for you to make connections, both with your mentors, with your teachers, and with your fellows. From the liver side, we're only going to be doing that in 2023, from the beginning of 2023. I'd like to invite you to, we have a hepatitis E symposium next Thursday, and we have an expert, Dr. Harry Dalton from the UK, who's really been sort of the father of hepatitis E. We'll invite you to attend that. And then on the I think it's the 24th of February, we have a 1.5-hour hepatitis symposium, which also covers everything from treatment to problems in terms of self-diagnosis, in terms of treating in pregnancy, and problems that actually we experience in treating hepatitis C in the setting of sub-Saharan Africa and difficult subtypes. So what we'll do is actually send you these invites and feel free to actually join. But I really encourage you to, after these sessions, to actually just go over them, highlight the problems that you're not quite clear on, and try and sort out these queries quite early on in these topics. Thanks, Mash.
Great, thank you, Wendy. I think those are very, very important comments. Thank you so much for that. I am mindful of the time. There are a couple of people I want to thank. I see some of the heads of divisions are on. So Neo, None, VG, Aso Bilal, and if I'm missing anybody, apologies, but thank you so much for joining. Really, really appreciate that you agreed to this and that you're supporting this program. I'd like to thank Janssen. They were really the first people who were on board with supporting this initiative. Monique is on, Monique van Veek. Thank you so much. Really, really appreciate the support. We cannot do this work without the collaborations with pharma. Really, really appreciate it. Karen, it's wonderful to see you back alive and in action. So thank you so much for all the work that you do in the background. Cheryl is not on, but thank you so much to her too for the assistance that she gives. And guys, you have my email. If there are any problems, if you don't understand anything, if you've got any concerns, please feel free to let us know. The idea really is to make you as comfortable and as happy as you can be during your training. I don't think there's any need for anybody to suffer alone when there's so many people that are more than willing to help. So do contact us with your queries, suggestions, problems, and we'll do what we can to assist. In 2 weeks' time, the next topic is, I've entitled it Approach to Dysphagia. But what Dr. Buerta, so Dr. Buerta is the country's, the continent's manometry expert. There's nobody like her. And she's agreed to do that session. And she wants to run it a little bit differently. So she's given us a lot of reading material that she please wants you, all of you, to go through. And then what she's going to do is that she's going to present cases and try to get through all that, the Chicago classification and all its ramifications, which is quite complicated. So please do your homework beforehand. Then you'll derive a lot of benefit from that session. Innocent Francis is still going to be the go-to person. But all of you, please, I'd like you to have a look at the material as Dr. Buerta has presented it. Kevin, am I forgetting any other important announcements?
I think you've covered everything, Nash. Thanks very much. And just
Yeah.
from my side, I've really enjoyed this. It's so lovely to be back. And, you know, the fellows always hold a special place in my heart. I really enjoy doing this.
Yeah, well, thank you so much. It's really been wonderful. And some of the fellows, only a few I've never met, but we will get to know each other better in due course. So thank you so much, everybody. Have a fantastic evening, and we'll see you in future meetings.
Goodbye. Good.
Thank
Bye-bye.
you.
Thank you.
Thank you.
you.